Hello, my name is Ken Miller. I'm a clinical educator of respiratory care services. I've been a respiratory therapist for almost 50 years, and during those 50 years, I've worked a lot with asthma patients. I'm involved in a lot of different asthma implementation programs, and I am an asthma educator at this point. So I think our topic today is going to be developing and implementing an asthma program to optimize outcomes. And I think it's very important that when you develop any type of strategy or any type of plan, regardless of what patient population you're really trying to target, is that one, you look at, what are the steps that can help you get to your target goals, and define what are the barriers that prevent you. And then once you achieve your outcomes, how do you maintain those outcomes? So we'll be talking about that throughout the presentation today. So the learning objectives for this presentation is going to be describe the magnitude of asthma in the United States. How does asthma impact our society in the United States? How many people have asthma? What is the severity of asthma? What is the cost of asthma? We're going to define the goals of asthma management. If we could paint the perfect picture of how we could maintain an asthmatic so they could have high quality of life and minimal symptoms and exacerbations. And then review different strategies to optimize asthma outcomes. What are going to be our countermeasures to address the patients that aren't reaching the goal of asthma management, those that are refractory to the basics care and the basics types of strategies that we implement. And then we're going to end up talking about methodology to assess improvement in asthma outcomes. How do we know after we implement countermeasures, implement steps, how do we know we've reached our target, and how do we maintain that target, and how do we assess going forward even other interventions that can optimize outcomes even better? So the magnitude of asthma is extremely impactful in the United States. One, it affects 9% of all Americans. Okay, so you talk about we have 300 million Americans. That is a significant amount of individuals that have asthma. And asthma is one of those cradle to grave type of diseases where it's can be manifested in young children and also very, very old adults. It occurs in 56 million billion in cost. So we'll talk about that a little bit more in detail. When we look at costs, typically in patient populations, we think about the cost of medicines, the cost of hospitalization, ED visits, those type of things. But there's a lot of other what you call soft effects where missed days, missed opportunities, and then also the quality of life. There are 1.8 million emergency room visits annually in the United States that are specifically, because of asthma attacks. So that's a significant amount of patients that go to the emergency room seeking help because they can't breathe and they have an asthma exacerbation. And it results into almost 500,000 hospitalizations where these patients in ED cannot get immediate relief and they meet certain criteria that they need to be admitted. And tragically, there's approximately 3,630 deaths a year from asthma. So you're thinking of, when you look at 365 days a year, almost every day there are 10 individuals dying from asthma, which is, you think in the year 2023, that would be something that would be hard to understand on why, since we understand asthma so much and we have so many medications. But, we'll talk a little bit more about that. But again, every day there's 10 patients dying from asthma attacks. Now, when I said to you this earlier, and this comes out of Australia, Asthma Australia, is that there's a lot of hidden costs. As I said, here they say almost close to $25 billion of the burden of disease. But there's 1.2 that go towards healthcare. There's 1.1 billion in productivity. Again, if individuals cannot work, they cannot be productive members of society. There's an average of 2 days missed a year because of asthma, being sick with asthma. Careers, this is interesting. $72.9 million is lost because of individuals that have asthma because they're sick, they're on medications, they can't interact in certain environments, they can't socialize always what they want, they can't engage in physical activities, they can be not, they lose the opportunity at times to promote. As we all know, if someone's sick too much at work, they get written up and thus they're not eligible to get advancements. And there's again, $289.4 million for support, meaning that if there's children that have asthma, there got to be somebody who stays home with that child. If there's people that have asthma, they may need special accommodations, things like that. So there's a lot of hidden costs of asthma, as I kind of alluded to earlier. You have that $28 billion, but the bottom line is $11,740 is the average cost of a patient having asthma. So you think about someone who has a diagnosis of asthma, they're going to pay at least $11,000 a year on their asthma. May it be missed days of work, may it be prescriptions, may it be healthcare visits, things like that. So when you look in the United States and you look at the self-reported current asthma prevalence, this is 2019 data, you can see where the darkened shade is, that counts for 10% of the population of that state. So states like Pennsylvania, Ohio, West Virginia are on the high side, and then when you go down to Texas, California, that seems to be on the lower side. New Jersey, for some reason, was not counted in the data at this point. So I think it's important too that you can see that there's a fairly equal distribution, because when you're talking the difference between 8% and 9%, here is not that great of a percentage difference. And so there's a large, there's like an equal distribution throughout the whole country. So asthma is not just a regional, it's throughout the whole country itself. Um, Again, one of the problems is when we look at the magnitude of asthma, as it's true for many chronic disease, a small fraction of asthmatic patients with severe disease, high vulnerabilities, and greater burden, barriers to consume health costs and resources. And this is the true is that, again, those patients that have refractory asthma, they have uncontrolled symptoms, they have multiple emergency room visits, hospitalizations, and even wind up in the ICU requiring intensive care and sometimes mechanical ventilation. They consume 80% of the cost, and the top 1% patients cost 25%. As I said earlier, these patients are also refractory to conventional asthma interventions, and they can run into lots and lots of expenses because they can't use the conventional therapies that are actually generic. They have to use the more non-traditional, non-conventional, which are often either experimental or very, very expensive. And most private healthcare plans provide, and most employees purchase care that implement plans with early interventions for high-risk patients and avoid health costs and health status degradation. So, it's very, very important that, if, we need to recognize what patients are at risk that fall into this category and be able to figure out how we can be proactive with this patient population and these individuals and not necessarily be reactive or proactive, reactionary in this sense. Because again, if you allow patients to have multiple exacerbations and multiple ER, be on, oral steroids, those type of like more, end of disease type of interventions. They will develop airway remodeling. They will have developed more comorbidities, diabetes, obesity, which then causes a cycle of other problems associated with asthma. So it's very important to, one, recognize the patients who are high risk and take, steps to try to prevent that high risk patient to continue to escalate into the healthcare system. And you can see we can look at the different steps here and assessments. You have asthma severity, which can be defined as intermittent, mild persistent, moderate persistent, or severe persistent. The severe persistent are those patients that we're talking about that often are refractory to conventional strategies, and they need biologicals or much, much more advanced interventions. And asthma can be either well controlled, not well controlled, or poorly controlled. When it's poorly controlled, those are the patients that are going to be in the ED, hospitalized, and are going to miss a lot of work, and their life is going to be controlled by asthma. They're not controlling the asthma. There's multiple comorbidities associated, allergic rhinitis, eczema, food allergies, obesity, bronchoalveolar dysplasia as a baby. There's a whole list of comorbidities. Okay, and then you can look at how we diagnose it with pulmonary function tests. We can use spirometry, look at lung volumes, exercise testing, and then try to sensitize. Looking at what is is it intrinsic asthma? Is it extrinsic asthma? Things like that. And then you look at all this and you put this into the bucket, and then you try to find a patient-specific asthma definition. Are they, mildly persistent asthma, poorly controlled, with allergic sensitization to dog, but they have normal lung function? So there are like 6 different categories here you can look at. Severe persistent asthma, well controlled with food and allergy and normal lung function. So the idea is to try to tailor the action plan and the care based on the individual patient, and just not lump all asthmatics into the same plan and treatment regime. Okay, because some patients are going to have different triggers. They're going to have different responses to the different interventions. So we look at the asthma iceberg here, and really, a lot of times, why do asthmatics even seek health care, or when do they worry about what's going on, is because they can't breathe. Dyspnea is really the top symptom, because that's what usually brings the asthmatic into the hospital or even seeking a diagnosis, because they have trouble breathing. They can't exercise. They can't go up a flight of stairs. They go outside. The cold air causes them to be short of breath. But underneath that is a whole gamut of other symptoms. So you have recurrent cough, recurrent wheeze, cough at night, persistent cough, exercise activity induced cough. Then you have airway inflammation, and then you have the airways are very sensitive to the asthma triggers, pollen, dust mites, and etc. So when you look at this asthma iceberg, often the first symptom that brings the patient into the healthcare system is that they're short of breath, they're dyspneic, and sometimes it takes multiple testing and assessments and diagnostic interventions to figure out if the patient truly has asthma or not. So when you look at the asthma definition, typically you look at the categories here as a patient at step 1. This is the medication that we should think about using if the patient is not controlled. So the maintenance medication, according to the Global Initiative of Asthma, is really inhaled corticosteroid. Used to be a SABA, a short-acting bronchodilator, but that should only be used as needed. That really, the maintenance drug is always now inhaled corticosteroid in the sense. And then if you go to step 2, where the patient needs more event, they may need a leukotriene inhaler, or they might need a higher dose of inhaled corticosteroid. And then now you go step 3, you start thinking about adding a long-acting bronchodilator. So this low dose could be Advair, 100 milligrams with 50 mics. And then step 4, you get into starting to use your higher doses of inhaled corticosteroids. So here you'd go from 150 of Advair to 250. And then you also think about when you're having some exacerbation, going to 500, and then add in some maybe anticholinergic or leukotriene inhaler antagonists like single air that can block the histamine allergic response, the leukotriene response. And then when you start looking at step 5, then you start thinking about, do we need to add biologicals, think about things like thermoplasty, more involved and more enhanced asthma management? Because one would argue that, 1 and 2 is considered to be controlled, 3 is, marginal control, and 4 and 5 are not controlled asthma. All right, and then again, when you look at this assess, adjust, review, response, how does the patient respond? And you look at risk factors, you look at other comorbidities, how well can the patient use inhalers, what is the patient's goal, what kind of symptoms does the patient have, and then talk about education and other non-pharmacological strategies like getting rid of triggers. So there's a whole gamut of different assessments that need to happen in this patient population. So when we get to the goals of asthma management, the main goals of asthma management are to optimize control of asthma symptoms and reduce the risk of asthma exacerbations while minimizing medication adverse effects. So we want to make the patient comfortable, we want to use the right medications, and we don't want a lot of side effects from that medication. So it's expected the person with well-controlled asthma would be able to participate to work, school, play, sports without being limited due to breathing. So if you're a child, you can go out and play with your friends at recess. If you're an adult, you can go hiking or have no problem with a walk behind mower, things like that. Have uninterrupted sleep, okay? A lot of times if patients have asthma, they have fragmented sleep. They're waking up in the middle of the night, coughing. Now, one of the things you should always rule out any patient that wakes up in the night with coughing is, do they also have gastric reflux disease? Because what they may have is actually a silent aspiration that goes in the airways and causes a reflex bronchial constriction to start. So again, the 4 essential components of asthma management are patient education. Patient has to understand their disease. And very, very important is they have to realize that even when they're asymptomatic, when they're feeling good, they still have a chronic disease. There's still inflammation. This is one of the biggest barriers on daily maintenance strategies in asthmatic patients, is because it's hard for an asthmatic patient, especially a younger person, to understand that they have to take their inhaled steroid every day despite them feeling very good and invincible and things like that. Minimizing exposure to asthma triggers. Okay, there's many other lectures that talk about all the different asthma triggers, but again, if you don't have source control, so someone has asthma and they're very allergic to their cat and they're constantly around their cat, no matter what medications you give, you're going to have some type of symptoms and lack of control. Monitoring the change of symptoms or lung function. That's why an asthma action plan is very, very important. And then what pharmacological therapy are they on? And again, our goal is to try to maximize the effectiveness of the drugs and minimize the actual side effects of these drugs. So the 4 essential components are patient education, minimizing exposure to asthma triggers, monitoring for changes in symptoms or lung function, and pharmacological control for daily symptom control. So these are what we're going to try to do. So when we implement asthma plans or we as a community are trying to reduce the amount of ER visits and law school days, work days in a certain region, in a certain, area. These are things we're going to do. Are we going to be able to achieve this? And if we can educate the patients, we can reduce the triggers, we can have the monitoring the symptoms and lung function, making sure they do peak flows and get PFTs, and they understand how to use their devices, what their drugs do, how to use their drugs, and they are asymptomatic for the majority of the days. That's our goal. So again, no symptoms during the day or night. So asthma should be, if you're well controlled asthma, it should be in your back pocket, meaning it should not have an impact on your day-to-day life, and it should not wake you up at night. You should be able to go out and play. You should not miss works because of that. You should have no exacerbations, or at least fewer, and not at all seek emergency room hospital visits for asthma, and last for not least, decrease the need for quick relief medicine. So if you're using your rescue inhaler more than 2 times a week, or you're being woke up with asthma more than 4 times a month, that meets the definition of uncontrolled asthma. So even though that doesn't seem like a lot, because 2 out of 7 isn't bad and 4 out of 30 isn't bad, that still means that the asthma inflammation is out of control. So that's what we got to really focus on, is try to get that in control so we can make sure that we meet the goals of the asthma management. So again, what we're trying to do is prevent this what I call this asthma cycle of doom. So we have the symptoms. We're dyspneic, we're wheezy, we're coughing, we're chest pain, we're waking up, we're tired during the day, and we have these acute attempts. So then that causes this burden, may it be emotional, financial, functional, and medication wise. All right. So we didn't talk about that earlier, but a lot of these asthmatics have emotional issues because they're very depressed, because they can't interact in society as they want to. And then you have different interventions. You have the pharmacological interventions, non-pharmacological, so for preventing the triggers, understand education, and then multidimensional assessment, quality of life scores, along with diagnostic testing, and the assessment of, how's the patient feeling, and then the impact, what is the impact of this? Motivation, physical activity, social life, employment, relationships, intimacy, travel, mental health. So again, all these kind of lead to each another. So this is a vicious circle. So if we can control the symptoms right up here, then we don't have the burden, we don't have to do non-conventional treatments, and we don't have a great impact in the patient in a sense. So again, asthma can be extremely burdensome, and it can cause a great onus on the individual because it may prevent the individual to have the quality of life that they strive to have. So when you look at this as, in a city environment, what are the different things that, are caused by the environment that individuals live in? Okay, air pollution, exhaust, cigarette smoke, you can have different types of burning, fires, things like that. So these all can cause asthmatic symptoms in the people that live, okay? Those that are pregnant, elderly, or their children. So we as a community have to try to understand that the way our community functions and the industry in our community and the way people's lifestyles are may have a negative impact on other members of the society. So those that smoke don't only impact themselves, but that secondhand smoke can cause asthmatic to become symptomatic and go into an asthmatic attack. Or if there's there's a lot of industrial plants that are swilling out a bunch of different type of contaminated type of exhaust, that can cause asthma attacks too. So again, you get decrease in lung function, increase in disability, increase in asthma-related costs, decreased quality of life, exacerbations, hospitalizations, increase in medication use, especially more expensive, and symptoms. So the community itself can have a role in causing the outcomes of asthmatic patients, because a cleaner environment will result in a much healthier environment for patients that have the diagnosis of reversible airway disease. And one of the things we got to be very concerned about is that based on, increased air pollution and a lot of climate change, there seems to be an increase in amount of prevalence. So in 2004, they predicted there would be in 2004 there was 300 million people with asthma. The prediction is that in that 20-year period, there's going to be a 25% increase or a 33% increase, I should say, in asthmatics, that there'll be 400. And there'll be a 50% increase of more, deaths from asthma. So in the world, looking at globally, there's going to be an increase in asthmatics, and there's going to be also an increase of deaths caused secondary to asthma attacks. One reason is they believe that there's a massive amount of non-compliance or adherence failure throughout the whole country, throughout the whole world. 80% of the patients don't use their inhalers correctly, or they can't physically do it. They're not cognitively smart enough or anything like that, or they don't have the physical dexterity to be able to actually squeeze the MDI. And 50% do not take their controller medications as prescribed. So this is a real big problem, because remember, it's a chronic inflammatory disease, so you have to take a maintenance controller drug. And if you don't, you are going to then make yourself more susceptible and more vulnerable to an asthmatic attack. So we talked about the goals of asthma. How do we, in a sense, what are we trying to achieve? So how do we know we're not achieving it? Well, we look at things like increased exacerbations, where we have patients that are more symptomatic, have more attacks. All right. There is increased work days or school absenteeism, in the sense there is problems with people at school not being there, children missing school, adults missing their work days. So all of a sudden, this is an asthmatic who had 5 days missed. Now they have 10 days missed. So, school missed 2 days. This year they missed 6 days. Next year they missed 10 days. Increased ED visits, increased hospitalizations. And, the pharmacy says that Ken Miller, he's supposed to be on a asthma controller, and he hasn't refilled for the last 3 months. So the lack of medication adherence, again, is another way we can look at. So we can look at, provider visit, we can talk to the patients and see what are their symptom control. We can look at school work records. We can look at ED visits, hospitalizations, and then pharmacy. So it's multidimensional in how we can look, how we can assess, and how we can determine that we're not meeting our goals. Now, there's a 6-step method to successful asthma management that all asthmatics should be aware of and should utilize when they see, their providers or basically have the diagnosis of asthma. Step 1, make your medical visits more productive. Make sure that you're reviewing information your providers are talking to you about and educating you about asthma. All right. That you're not just going there and be given a medication and not really understand how the medication works, 2, why you get a medication, and what are some other interventions. Okay, create an asthma management plan. All patients should have an asthma plan that is specific for that patient, looking at individual triggers, looking at individual symptoms, looking at individual medications and individual goals. Okay. Assess and monitor your control. All asthmatics should keep a diary of how do we feel. So I know myself having asthma that when weather changes abruptly, if we go from a very humid day to a very dry day in the summer, or we go to in the fall to a very, a moderately cool day to a very, very cold winter-like day, that's going to cause my asthma to act up. I have to be careful if I'm outside, because that weather change and that dryness is going to trigger my lungs a little bit. As I said, understand your medication. Know the action of the medication. Know the side effects. Know the dosage. Reduce asthma triggers. What is causing my asthma? All right, and then learn asthma self-management skills. So it's a two-way street with asthma. It's not only that the provider and the clinical team has to be engaged in trying to help the patient. The patient has to try to help themselves, which a lot of patients will take on the onus of trying to be a self-directed advocate for their asthma. But others, one, aren't cognitively understanding it. Two, they have other barriers that don't allow them to be successful. And we'll talk about that in the near future. So the 4P healthcare stakeholders in any type of chronic disease, may it be asthma, may it be COPD, congestive heart failure, diabetes, is that in a healthcare system, we call it ecosystem, there's the patients, the providers, the payers, and the policy chain, the policymakers. They all have a different role in the healthcare, which means that they have different interests or visions that also play a role. Obviously, payers want to try to pay the least amount of money they can possibly, for asthma management. Providers want certain things, patients want certain things, and then obviously policymakers, may it be at the state, federal, local, state, or federal level, like, Medicare, Medicaid, or, some other laws about medicines. We do know that the present, the current administration has tried to reduce the cost of some medications because they have become totally out of, basically totally out of control in price, and becomes a major barrier for a lot of patients, insulin for diabetes, and, anticoagulant therapy for patients that have chronic emboli and things like that. So these are the different stakeholders in healthcare. Understand they're all going to have their own vested views, interest, visions. So this is just a picture of it, okay? They all interact in the same, they basically interact in the sense, and it's a cycle and stuff like that, but they all play a role in the outcome of any patient with any chronic disease, and especially with the patient with asthma. So, one of the major players and one of the what I noticed when I took the asthma educator certification, there's a lot of questions there, that are based towards pharmacists, because a lot of pharmacists are asthma educators too, because obviously they're very integral and very involved in the actual administration and distribution of these medications and that. So I think, when you look at the role of pharmacists in asthma management, they're involved in screening and identifying patients at risk of developing asthma exacerbations. If they have a patient that's coming in there frequently and refilling their rescue inhaler, that should throw up a red flag. Why are they using a rescue inhaler so much? Creating awareness among patients about triggers, exacerbations, and other strategies. So we often think of this as the nurse, their respiratory therapist, or the provider, but the pharmacist plays an integral role in the management of asthma, because one of the major components is medication, pharmacological intervention. Recommend an individual treatment based on disease severity, phenotype, and control. Is there special type of drugs or special type of maybe biologicals that this patient would, especially a patient that has severe persistent, would they be better as? Are they eosinophilic or are they neutrophilic type of asthma? Encourage medication adherence through patient counseling. Make sure they know how to use their inhalers. Make sure they have a spacer to use them with, and make sure they understand the side effects. And then again, educate them about the disease, inhaler technique, and refer patients or specialists for further care. So if I'm a pharmacist and I see a patient that appears to be non-controlled with asthma, I want to get them to an asthma specialist. May it be a pulmonologist, allergist, or etc. Get them to somebody who can really drill down and do more advanced technological and diagnostic type of assessment. But the pharmacist, and that's one thing to understand when you take the asthma educator certification exam. There are many professions that are asthma educators, caseworkers, pharmacists, physicians, nurses, respiratory therapists are just a few. So, okay, now this is kind of interesting. Is for the patient, what is the right class of medication? So I think this is very, very important too. So when you're looking at the medication, or you're a pharmacist and you're trying to distribute medication, you have certain goals. One, is it the right medication for the patient's symptoms and disease? Two, is it the right medications for the patient's intellectual level and physical capability? Two, does the medication have an impact on the environment? Years ago we used to use the ones that shut out freon and stuff, and we saw that was bad for the environment and that. And then, is there a better way of administering this drug? So if a drug's PO and that gives a lot of gastric side effects, can I give it inhaled? And if I give it inhaled, can I give it should it be with a nebulizer, MDI, or DPI at this point? So again, this is, for the patient, the right class of medication. Think about not only in the terms of, is the medicine right for the symptoms, but is the medicine right for the patient? The device right for the patient, and what impact do we have on the environment with these medications also? So it's multidimensional, as a lot of things are in this presentation. So the countermeasures to try to figure out how to improve outcomes is an effective approach is needed to find high-risk patients, implement appropriate interventions. So we want to we don't really, it's not that we don't care about the Controlled Asthma Act, but those aren't the ones that are causing the problems. We want to try to get the ones that are high risk, implement appropriate interventions to improve outcomes and reduce cost and resource allocation. Care management usually is a cooperative process to assess, plan, coordinate, implement, evaluate, and monitor services, and try to come up with options to fulfill the patient's health and service needs. Again, a care manager, a lot of times you see them in COPD, the asthma care manager, again, is going to help call the patient, see how they're doing, make sure they're getting the health and related services, and make sure they make certain medical appointments. Again, asthma exacerbations make up almost 2/3 of the annual hospital cost. So if we can reduce asthma exacerbations by 40%, and we can increase adherence by 50% and improve quality of, we can actually impact not only quality of life, but we can reduce costs and the burden of asthma significantly. But unfortunately, because of lack of resources or lack of communication and organizational barriers, only 1 to 3% of asthma patients are enrolled in these care managements. So this is a potential countermeasure that can be very beneficial moving forward, that if implemented, just up to 15%, as the goal is it can have a tremendous, tremendous impact. So again, what you want to look at is both short and long-term goals for these patients. So again, you have to define non-traditional asthma services for high-risk patients. Are the initial steps, can we find the appropriate definitions? Can we find where the gaps are, and can we fill in those gaps? And then long-term steps is, how can we provide the highest value service for the high-risk patients? Use payment reform, again, try to define population outcome measures, implement funding mechanisms, establish management structures, share resources, and accountability across healthcare and social service silos. Try to integrate into, make sure you have all the services providing for the patient. They're all communicating each other, and everybody knows what everybody's doing, and everybody's has their own level of expertise, an integral part of this puzzle, but they all communicate and they make sure there's a continuum of care, not with gaps of care. And then improves information sharing and coordination. Make sure that we have databases, we have information. So if for example, a child who has asthma, that information is relayed to the school that the child is transferred to. And so the school nurse, the teacher that's taking care of that child, or if someone moves from a urban area to a rural area, that care can continue in the rural area, and then we don't have these gaps of care. So really is try to, define the individuals we're trying to really focus on. Make sure we have the opportunities to do it in the sense of cost, the best practices. Make sure we implement programs that have shown to improve outcomes, and then make sure that information is shared among the different disciplines so everybody knows and has defined goals. So ideally, what asthma patient can benefit from this? Ideally, the asthmatic patient enrolled should be those at high risk. Predictive modeling is the best method to find high-risk patients. It uses models predicting individual patient costs or healthcare outcomes to automatically find high-risk patients. So one of the things that we do at our institution is any patient who's admitted to the hospital that has asthma is automatically seen by an asthma educator to try to drill down on what's going wrong. Because we really truly believe if we can control asthma, we should be able to prevent patients from being hospital because of asthma, especially if they require ICU. We just had a patient recently who required mechanical ventilation, and then I myself visit with the patient, and one of the problems I saw was that this patient knew about their disease, but they didn't have the financial abilities or the transport abilities to get their medicines they need. So again, costs reflect use of efficient care and indirectly cause of hospitalization, ED. We want to try to minimize that. For patients that are predicted to have the highest cost of work outcomes, we want care managers to look at the records, drill down, consider various factors as social, as I said, with this individual, very nice individual, but didn't have money for medications, didn't have a way to pick up medications. How can we fix that? And then make sure that we're using the proper allocations and intervention decisions to optimize the outcome for these individuals. But again, we're limited at this point because the identification methods have limitations, because a lot of times there's poor documentation, there's fragmented communication, and there's insufficient resources. But this would be, the individual we're going to look at the highest risk. So one of the things we try to do is monitor trends, track progress, provide information, disseminate data to improve outcomes using, data and surveillance, medical record numbers, community outcomes, look at environmental approaches. We try to enforce healthful behaviors in school, childcare, work sites, create awareness of asthma, triggers and environment factors that affect those living in asthma. Again, one of the things we talked about educational strategy in asthma is, at schools need to be aware that, if they're going to have a classroom pet and it's furry, it may cause a child or two that has asthma in that class to have an exacerbation. Okay, or if they're going to clean the rooms over the weekend, then on Monday, if there's residual smells or triggers, that may cause problems too. So you got to look at, got to be a continuation. Okay, healthcare system interventions, improve the effectiveness delivery, make sure patients aren't missed on discharge, because you don't want an asthmatic to just be discharged without explaining to them what their medications are or how to use their inhaler devices, okay, and make sure that we're going to eliminate the causes of asthma. Again, as I said just earlier, if we don't have source control, we're just going to have a cyclic circle of the patient leaving the hospital, getting in contact with triggers, coming back to the hospital, leaving the hospital, and then going back to again their triggers. So again, eliminate risk factors and manage asthma complications. If you're obese, try to lose weight. If you have GERD, take a proton inhibitor medication, etc. And then connecting the clinical services to the community programs and resources. Make sure people are aware of what's out there to help them to, one, understand their disease and be able to help them manage their disease. So again, you look at a charter here to improve patient care and severe asthma. It's referrals, a formal diagnosis, understand the severity of the asthma. They deserve the care they need. They don't want to be reliant on corticosteroids, and they deserve access to the quality of care that they need. So this is an individual patient charter that a patient that has severe asthma sits down with a care manager, and they go through each of these steps. So the care manager and the patient with severe asthma has an understanding and an agreement that this is what the care manager is responsible for, making sure that I can afford my medications. There's ways that I can get my medications, and the patient is responsible for, they're going to use their medications, they're going to monitor symptoms, and they're going to be in contact with the care management if their symptoms change. And 3, they're going to be an active participant in trying to get better by avoiding the triggers or doing everything they can to try to maximize the environment they live in for asthma. So this is a two-way street, and this is a charter that the care manager and the asthmatic patient sits down and works together as a toolkit. So those are some things we're looking at, but where are the barriers? Where are the barriers? So again, current predictive models of individual patient costs and healthcare outcomes exhibit poor accuracy, causing misclassification needs improvement. One of the problems is someone comes with an asthma attack and the ER provider puts down as the patient was short of breath and puts down a different diagnosis at the time. Maybe he thought the patient was in heart failure or having a heart attack, and then it's the patient isn't even classified as having an asthma attack. So you can be very, very careful with that. There's over 20% errors in the average cost that, there's a 20% error of what actually things cost, and in reality they do cost in a sense. There's only a 0.8 accuracy of the measure, and the enrollment miss is over 50% of patients that could be benefited from a care, and studies show that more than 1% who had the largest costs, almost 50% of them. So if we could just get the 10% high-risk group identified by a predictive measure, we could save almost $210 million in asthma care and obviously also increase the outcomes. But because there's poor documentation, there's poor assessment, there's poor follow through of different type of goals, then we have these barriers to success. The other problem is, are the social needs of asthma being met? There's a good lecture in this series on the disparities of asthma. And one of the problems is persistent asthma severity is also associated with several unmet social needs. It includes in housing quality, stability, lack of food, transportation, and healthcare costs. If you can't do the basics of asthma management, you're not going to be able to do the upper level. As I say, if you can't get the low-hanging fruit under control, you're not going to be able to reach the high-hanging level goals. So this is, barriers to adopting an evidence-based treatment into clinical practice. There's patient-related barriers, low health literacy, beliefs and misconceptions, social culture norms, and economic barriers. So there's the barrier for patients. There's institutional barriers, limited resources, cost of availability of medication, lack of clear plan of dissemination of treatment recommendations, lack of viable implementable strategies. Okay, and then at last there's physician or provider, lack of time, lack of training, knowledge, and resistance to change. We have one or two pulmonologists that are still ordering drugs that they were using 30 years ago for asthma and don't even know that there's biologicals that are available today for asthma management. So you can see there can be three different types of barriers here. And obviously they can be all interrelated or they can be individualized. But the bottom line is they can't get past this next step or through the roadway to success. So again, this is from allergy and asthma, is path to achieving health equality. Again, if people are living in squalor neighborhoods and there's a lot of triggers, how's the asthmatic going to do? Do they have food security, access to healthy food, vitamins? Do they have stable income and job security? Do they have money to pay for their medications? What's the environmental quality of the areas they're living in? Affordable health care. Okay, you know what the cost of health care is if you don't have insurance. Do they have educational opportunities to really move forward into their lives and get to the next level? Are they living 10 to a room? Are they living in a house that's clean? Or is it filled with cockroaches? And there's a lot of discrimination, unfortunately, on minorities, even in this day and age. Again, you look at Black Americans, 1.5 times more likely to have asthma. Puerto Ricans, 2 times more likely. Black Americans, 5 times more likely to go ED. 3 times more Black Americans are likely to die from asthma. Okay, 1.5 Black children, allergies, food allergies, die from anaphylaxis. So we know right there that the African American population is at high risk for asthma and severe exacerbation of asthma at this point. So what can we do about that? Another barrier. These are asthma take plans, okay? Again, when you look at healthcare disparities at this point, Native Americans 30%, Puerto Ricans 2 times likely. Factors that can lead to this asthma disparities. They don't have transportation, they don't have money, they're involved in triggers, they don't have the education to understand, and they don't have the ability to even understand because they may not have the same language. They may be language barriers. So I think it's very, very important that you understand that one of the major barriers and one of the reasons that we have some high-risk patients is not necessarily they have uncontrollable disease. They don't have the same opportunities to get their disease under control. So these are some asthma resources that are available that we talk about is the Allergy and Asthma Network, Mothers of Asthmatics, American Academy of Allergy and Asthmatic Immunology, Asthma Allergy Foundation, American Lung Association. These are asthma resources that everybody can use to help understand what asthma is better and are very helpful for patients so they can understand their disease process better. Exhale is an acronym that's always used, is education, extinction, so education, asthma self-management, extinction, getting rid of secondhand smoke, home, getting rid of triggers, achievement, are we reaching our goals? Are we able to coordinate linkage around the care across different settings? So if the patient is in the ED, do we set them up with follow-up care? And then environmental to make sure that we can reduce indoor, outdoor, and occupation sources of causing asthma. So this is the exhale type of program. So we look at society, healthcare systems, neighborhood, child, and family. They all play a role in asthma, looking at public advocacy for policy changes, healthcare systems. Are we cross-cultural communication? Are we provider training so they understand? What are the high-risk groups? Where are the neighborhoods that have increased amount of asthmatics? Are we having community centers, green space? Do we have public safety forum? And then can we educate the child, the family, and all individuals about asthma and the importance of being able to, control their asthma with medications and environment? Now, how do you know if your program's working? The Wisconsin Department of Asthma, they had a pilot program that they looked at 6 million state residents, and they focused on children, low income, racial and ethnic minorities. And what they looked like at was they built a program that demonstrated a successful return on investment. So what they tried to do was take these high risk patients and make sure that they could target programs and interventions and countermeasures that would be germane to this patient population. And they saw a 45% reduction in asthma-related emergency visits and an 88% reduction in asthmatic hospitalizations. So this is an example of a program that was instituted that had fairly good success. And they had the Asthma Safe Homes program where they identify and fix asthma triggers in the home. They learn better control of asthma, live your best life, and save money by using less asthma medication, fewer trips to emergency rooms of care, avoiding overnight stays in the hospital, missing fewer days of work. And then they gave money to help home assessment repair services for eligible clients. So, for example, if they had leaky pipes that could lead to mold, and mold's a trigger of asthma, they would actually replace those pipes. They got free products to remove asthma triggers, like maybe filters, get pest control in to get rid of cockroaches. And the idea was to create a healthier home. And again, the component one was in-home asthma education and asthma products. There was either 2 to 6 visits, and during those topics, visits, they looked at asthma self-management on triggers, home walkthrough, referral for home repairs if a major asthma trigger was identified, and then $1,000 of free asthma-friendly products, which includes dust mite covers, pillows, mattresses, cleaning kits, vacuums with filters, home air cleaners, air conditioners, and more. So this is what they instituted to optimize outcomes. And then component was a trained asthma home assessor came in, and we gave up to $5,000. Again, eligible home repairs, get rid of mold, carpet removal, pest control, leaking or roof repairs, drafty windows, and then they also got free home repair with certified contractors. So they gave $5,000 to try to improve the environment of these patients, and you can see it had a very, very improved outcomes. So metrics to asthma success is you look at reducing the asthma attacks in a year, reduce them by age, gender, race, excess poverty level, and the area. So these are metrics to asthma success. You try to reduce these things in these areas. And again, what is the benchmark to good asthma control? No coughing and wheezing, no dyspnea, being able to sleep through the night, normal physical activities, no absence from school, secondary asthma, and no missed time from work or parent. Remember, when a child gets asthma, someone has to stay home with that child, which means that the parent is going to miss work also. So the child misses school, the parent misses work. And for people that have marginal incomes, this can be a major, major problem. So when you look at this, United States 2001, you can see that 8% of asthmatics are adults, 6.5 are children, sex is male, female, it's pretty well, more females than females, and then whites, black is the highest percentage with whites, and then Hispanics. And when you look at community asthma intervention, this was from Children's Hospital, how do we know? Well, 68.5 emergency room visits for asthma after their intervention of getting through, getting rid of environmental triggers, understanding how to use your medications, checking their houses. We went from 68 to 22, from 51 to 7. So this is a tremendous drop, 85%. And then missed school days, 95 to 56. That's a 41%. And missed work days was 75 to 37.5. So it very, very positive outcomes if you do the correct interventions. It was at Children's Hospital in Boston. So in conclusion, asthma is a very common disease in the United States. Almost 1 out of 9 people. Asthma exacerbations cause a matrix of problems, anywhere from discomfort to hospitalization. There are many barriers to achieving successful asthma management, may it be financial, transport, literacy. Develop an asthma action plan can achieve successful asthma symptom control. I think it's very important that it's a co-partnership, both between the asthma educator and the patient. Assess an asthma outcome metrics to help direct and maintain beneficial programs. And I think it's, as I said earlier, it's super, super important to be able to, one, measure what your targets are and assess your outcomes, and continue to assess if you're maintaining, and then take other countermeasures to even improve better. Never being happy with where you are, always trying to get better. And asthma prevalence may increase in the future based on the data we saw, both in prevalence and in deaths. So if you have any questions, I'll tell you how to get a hold of me. I want to thank you very much for listening to this presentation. I really appreciate it. If you have questions, there's my email. I'll be glad to entertain them. And again, thank you very much. And I have some good references here if you want to expand on your knowledge of asthma and the community, and what is the role of asthma educators to try to optimize outcomes. So again, thank you very much.